let's talk about the complications of twin pregnancy. So we have the maternal complications and the fetal complications. In case of maternal complications, we know the changes of pronounced hemodynamic changes happens. That is, mostly the changes in pregnancy happens is increase in heart rate. Everything increases in case of heart. Stroke volume increases, cardiac output increases, whereas the total lung capacity decreases. So to compensate that, we have more tidal volume and more inspiration capacity. After all, it have to support two lives. In case of blood, the proteins increases but the plasma increases far more. So the RBC, after all what happens, RBC increases but hemodilution happens and we can see physiological anemia. Here also the proteins increases, all the protein increases mostly. So hypercoagulation state can be seen, as well as hypertension, hyperglucose, that is gestational diabetes mellitus, and also the urine output, vomiting also increases as well. Urine increases means what? GFR and all the other things increases as well, whereas the GI motility decreases, and that's why constipation can be seen, and the motility decreases, so gallstones can be seen. That's the part. Highlights. Next, placenta size increases. So what happens due to placenta size? First one is obviously HCG production increases, so hyperemesis gravitarum can be seen. Human placental lactogen increases, so gestation diabetes can be seen, risk increases. And also due to more exposure of paternal genes, we can see preeclampsia. Preeclampsia means 140 by 90 plus, and or 160 by 110. So if I write here what we have, preeclampsia 140 by 90, or in case of severe we have 160 by 110, along with proteinuria. So protein increases in urine, so that is more than 0.3 should be there in dipstick, more than 0.3, and also on the platelet should be less than 1 lakh. The serum creatinine level will be more than 1.1. Liver enzymes will be double, will be 2x in this case. We have other problems like মাথা ব্যথা হবে, চোখে ব্যথা হবে, so visual symptoms, headache, everything, or end organ damage. So this is preeclampsia. We can also see abruptio placenta, that is due to preterm level and premature rupture of membrane, abruptio placenta, and placenta previa can be seen. Whereas also intrahepatic cholecystitis, acute fatty liver of pregnancy seen, polyhydramnios seen as two babies are producing urine. So risk of preterm labor, premature rupture of membrane, postpartum hemorrhage, cord prolapse, and malpresentation is seen. Obviously babies can run idhar udhar because of more swimming pool, so malpresentation. Next, twin pregnancy is risk factor for pregnancy induced hypertension. That's why we give prophylaxis of aspirin. How much dose? 80 to 160 or 150, given before 16 weeks, that is 3 months, before 3 months. Okay, now what are the fetal complications? So the most common complications in seen what were in monochorionic. Monochorionic means monozygotic. MC is implies it is MC, okay, but not the opposite one. Now one thing is more in case of dizygotic twins, that is chromosomal abnormalities. What happens in chromosomal abnormalities? the more the sample size, the more we have the risk of chromosomal abnormalities. So in case a chromosomal abnormality in normal population is X%, in monochronic or chorionic, that implies monozygotic, I have X%, but in case of dizygotic, that implies automatically it is a dichorionic, I have 2x% chance because the sample size increases. So increases with sample size in case of chromosomal abnormalities. Okay. Now, what is the next part? That is the applied aspect. Testing for aneuploidy is for monozygotic. We can sample from any twin because same zygote. In dizygotic, sample taken from both the twins. The prognosis depends on chorionicity and amnioticity, but in case of preterm labor and intrauterine growth restriction, the more the number of child, more twins, the more it is dangerous. So in multifetal pregnancy, we have to do fetal reduction. That means if I have, as per the books, if I have 4 babies, fetuses, I have more risk of intrauterine growth restriction. After all, there is no space, and preterm labor. So what I have to see the most viable ones and remove the other ones. So I will find the most viable ones. So the risk of these two remains, but it lessens. It is too much risk, it is lesser risk. Okay, so how to check the most viable ones? I have to see which ones are the most promising, and 6 is not considered one of the parameters of choosing the fetus, so it is not same. The other two were not qualified, not so viable. I have to then give them potassium chloride injection given to the fetus with the least chances of survival. Intracardiac potassium chloride given in the 10 to 13 weeks, 10 weeks, and it does not affect the survival of the other fetus. Let's talk about the next part, that is complication common to the all twin pregnancies, that is preterm labor is most complication, intrauterine growth restriction obviously, and congenital anomalies. In case of primigravida female with no history of preterm labor or no second trimester abortion is seen, then cervical cerclage is not done just to prevent preterm labor and second trimester abortion. We know cervical cerclage can be done in case only with a history of 2 second trimester abortion or 1 second trimester abortion and small cervix on USG in the current case. Now, what are the congenital anomalies that can be seen? The most common congenital anomaly is in case of seen in case in twins, and in twins is more in monochorionic. Okay, so we have multiple defects that can be seen. That one is heart defects, twin to twin transfusion syndrome, most common in monochorionic twins, because yes, we have just studied that they share some deep vascular connections in this page. Next is what can be done. We have in echocardiography or level 2 scan, that is a target scan or anomaly scan, is done in all pregnant females to rule out gross congenital anomalies of fetus. So TTS can be found in that time. Now, what is a vanishing twin? Vanishing twin. What is a vanishing twin? It is a twin pregnancy, early spontaneous reduction to the singleton pregnancy, common in case of IVF pregnancies. Effect on the second twin is a normal survival with a low birth weight or small for gestational age. Next, death of one twin. What happens? We have two cases. We have one surviving dichorionic twins. The complication is less due to absence of vascular anastomosis. The dichorionic twins doesn't share anything, as this picture. The dichorionic twins doesn't share, so if one gets rid of, the other one will be simple same. Whereas in case of monochorionic twins, they share the vascular anastomosis. In case of MCD, diamnionic case, they share deep vascular anastomosis. So it can be seen that one of the twin is dying, so that's why the other, it is a low blood, low pressure zone. So blood comes from the other child to this one, and this is the used blood that comes in this baby. Okay, that's why this, the high pressure system is doing, who is going to live, his BP also falls, his blood level is also falls, so anemia and exsanguination can be seen. So death of twin A happens, so it dies along with killing it as well. So in examination, if I see children is died already, then there is no problem. Whatever damage has to be done has done, was to be done has done. So I will do a normal delivery on normal time. But if I see one twin is about to die, if it is about to die, then I have to do an early C-section to bring both of them out, and I will be able to at least save one of the twins. Okay, so that's what it is written, that in case of the death of one twin, the surviving other twin, no need for immediate delivery. But in case of impending death of one twin, so one is getting died and he is killing the other one as well, so do immediate C-section, and I will be able to take out both twins. At least one will be survived. So that's what it is written in here. Now, specific complications in monochorionic twins are TTTS, that is twin-to-twin transfusion syndrome, obviously because they share blood vessels, twin anemia, polycythemia sequence, TAPS, twin reverse arterial perfusion, and selective IUGR. IUGR is seen in all twins because obviously there is a limited space in mother's uterus. So if two babies are sharing this, obviously growth will be limited. But in case of monochorionic twins, as they share common things, we have seen one is small, one child is small, other one is normal. Okay, this is case of selective IUGR. So one gets big, another one doesn't get anything. Okay, now twin-to-twin transfusion syndrome. What happens? So it is a socialist thing, it is a capitalist thing, you can say. Monochorionic is what I mean, it's a monopoly kind of. So it is kind of monopoly. So one gets big, and other ones get smaller, and it is all twins are more or less socialist. They distribute things. Now, what happens in twin-to-twin transposition syndrome? It happens in case of only monochorionic. So dichorionic is not seen because there is no vascular connections. In only monochorionic children, it is mostly monochorion. That is the outer one is monochorion. Diamnion. It is the most common case. Okay, because these babies share some deep connections, deep vascular connections. So what happens? Only one way of blood flows. One gives blood, one takes blood. So one gives blood, one takes blood. What happens? Because it gets more blood, it makes more urine, and it makes less blood, so it makes less urine. So oligohydramnios and polyhydramnios, oligohydramnios and polyhydramnios can be seen. On USG, the single largest vertical pocket is measured to check for oligohydramnios level. Next, as it has less blood, so anemia can be seen. So heart failure happen. It has more blood, so it has to do more pump out blood, more work. So here congestive heart failure can be seen. So polycythemia and congestive heart failure can be seen. Thrombosis can be seen as well. Middle cerebral artery peak systolic volume. In case of anemia, it is always more than 1.5 MOM. It is always more than 1.5 MOM. Okay, so more than 1.5 MOM. That's how we actually measure polycythemia or anemia. In case of polycythemia, it is just half, so less than 0.8 MOM. Complication in both cases is hydroxypyrosis and death. Now, as it gets less blood, so it makes less urine, so obviously the GFR will be less and GFR will be more. GFR less, so renal blood flow is also less. So we have a risk of renal failure, kidney failure in these children. Now in the picture we can see this. This is what happens. This is a stuck twin. This twin that is stuck one side, it has less urine, so it is oligohydramnios. This is the donor urine, and it can have a renal failure. And whereas the recipient is receiving everything, so it has polyhydramnios. Can make malpresentation can be seen in this case, and cord prolapse can be seen. Whatever, we have twin born with TTS. One will be pink, one will be pale. The picture is not so clear. This is a pink, and this is a pale baby. Pale. Okay. The single largest vertical pocket on USG is the best method for amniotic fluid assessment in twin pregnancy. Okay. Now management. In case of USG findings, we have monochorionic diamniotic case, polyhydramnios in one case, oligo in the other twin. The earliest marker is nuchal translucency, that is the neck translucency in T1 can be seen. I have already told you that T1, the best time, the window is 7 to 14 week. So best time is in between, that is 10 week. What happens in this stuck twin, that activation of RAS happens. So oliguria, anuria, anhydramnios can be seen. In this case, RAS what does? RAS increases the BP and volume. Now, quintile staging of TTS. What happens? One twin will be in TTS means one twin will always be in polyhydramnios stage 1 and stage 2. Other one is in oligohydramnios stage. But in the stage 1 the bladder is still visible, so there is some urine in the bladder. In stage 2 there is no urine, that is anuria in the bladder. Doppler findings are both in this case are normal, but if things worsen from there, then we can see normal, we can see abnormal Doppler study. Then in stage 4 hydrox fetalis in one or both twins. Stage 5 is death of one or both twins. Now what are the follow-ups that we have to do? That is in Doppler we have to do Doppler study, USG and echocardiogram of discipline twin. So the first one is Doppler studies done in 16 to 20 weeks. Umbilical artery, vein, ductus venosus, peak systolic volume of middle cerebral artery is seen to assess the anemia or polycythemia. In USG, we see the fetal biometric growth assessment is done. Polyhydramnios can be seen, and diagnosis of hydrocephalus can be done. In echocardiogram, the most important thing is right side dysfunction can be seen in the recipient twin, because after all it is receiving more blood, so pulmonary atresia or stenosis hypertrophy can be seen, and right side dysfunction can be seen in the recipient. Treatment: if it is found before 28 weeks, that is viable, so fetoscopic laser ablation of vascular anastomosis can be done. If it is more than 28 weeks, that is serial amnio reduction can be done. That's it. Now other complication is what? This is TTTS. It is just the smaller version of what we have already seen. Okay, if suppose we have done fetoscopy laser ablation of vascular anastomosis, there will be still some small connections present there. So slow perfusion of RBCs through few small placental arteries anastomosis can be seen, and that's it. It is just a milder chronic form of TTTS. So after treatment, of TTTS, I can see caps. See, that is written post laser ablation of TTTS. Upper spontaneously or post nasal happens. Here, as the slow transfusion happens, so here can be seen anemia and polycythemia as well, but the amniotic fluid will be normal because they are making their own urine, so no oligohydramnios or polyhydramnios. But as there is anemia, so it will be how I know it is anemia. So peak systolic volume of middle cerebral artery on Doppler study says it is 1.5 mmol, more than 1.5 mmol. This. Next is twin reversed atrial perfusion, that is TRAP. What happens? It is a rare complication in monochorionic twins. One has a normal beating heart, one has a normal heart, the other one is a sigma male, so it has no heart. So it is a acardiac. So what happens? This normal baby sends its blood, deoxygenated used blood to the other guy who has no heart. Now that's the case. Outcome. What becomes the outcome? It is a normal one. It is obviously a dysfunctional child. So the outcome of the acardiac twin is either it has a acardiac acephalus, that means no head, only the lower part is developed, acephalus. Acardiac amorphous, that is, it is just an amorphous mass, no parts are developed. That's it. That's the case. And why it is called reversed arterial perfusion? Because normally the normal case umbilical vein supplies blood to a baby, whereas here in caps trap, umbilical artery is supplying blood to this baby, to cardiac, no heart baby, no heart baby. That is this one. That's why it is called as reversed arterial transfusion. Let's talk about next one, that is selective IUGR, seen in monopoly, that is chorionic monozygotic twin. The one is normal twin, the other one is a small twin. So how we know it is small? It is fetal weight is less than 10 percentile of the normal fetus, or more than 25% discordance in weight. Okay, so if it has 2 kg weight, it has 500 gram weight. It's 1.7 kg weight. Sorry, whatever. Causes is unequal placental sharing, both using same placenta, because they are monochorionic, that implies it is monozygotic. And unequal splitting of initial cell that can be happen. After all, they are monozygotic mostly. What happens in case we have cord entanglement and conjoined twins? Cause is formation of true knots. Management is C-section, 32 to 34 weeks. Now, how to deliver a twin pregnancy? The first twin is closer to internal loss. What comes first in our hand? During pregnancy comes out first during delivery. Presentation, both twins are in vertex position, that is the most common presentation. First twin vertex and second twin bridge, that is second most common. Now we have some complications seen as interlocking of twins, seen in one twin in bridge position, the other one is in cephalic position. Now if I just take out this one, takes out this one first, I have this situation, both heads are in the cervix and they are stuck, so we have to do C-section, never vaginal. Now let's talk about the mode of deliveries. Mode of delivery in case of depends on the presentation of the first twin. Okay, so we do vertex presentation, then vaginal delivery, and bridge or transverse, then we do C-section. If both are in vertex position, okay, the vertex position, we have three things. That first twin comes out as vertex position, so we always do vaginal delivery. Now in case of the second twin, if it is in the vertex position, we will do vaginal delivery. If it is in the bridge position, we know we have to do assisted bridge delivery, that is also a vaginal delivery. But it is in transverse position, obviously the worst one, we shift to OT. We do internal podalic version, that means we push our hand inside mother and rotate the baby, take it to the bridge presentation, that means baby's legs are grabbed and we pull out it from there. Now what is important, that if we do put our hand inside the body, we have to give general anesthesia. Okay, second twin in transverse line, and it is contraindicated if there is a previous history of C-section, so we don't do that. We do give general anesthesia, hand inserted into uterus, feet of baby is pulled and rotated to convert it to bridge, from transverse to bridge. We just hold the baby's hand and make it bridge presentation. external cephalic version is only if membranes are intact. Okay, that's it. Now, in case of twin delivery, after the delivery of the first twin, that is most probably vertex, we don't give methyl ergometrin because it makes uterine causes uterine contractions and it will kill the second twin. We can give oxytocin but not methyl ergometrin. Maximum time gap between the two deliveries is 30 minutes. If it exceeds 30 minutes, we have to do C-section of the second twin. That's it.